Good morning. My name is Daniela Lazea. I'm one of the anesthesia and critical care attendings at Brigham and Women's Hospital. And today we're going to talk about the management of patients with left ventricular assist devices who are coming for non-cardiac surgery. And I'm going to start with a case. It's a 56-year-old male who fell from a bike. He was intubated at the scene for a low Glasgow score, and the neurosurgeon is calling you because this patient needs to come to the OR immediately. He's hypotensive, tachycardic. He received already 1 liter of normal saline, and he has an LVAD. And just to make sure you understand the emergency of the surgery, he sends you a picture of the CAT scan. The objective of this lecture is to understand the components and normal VAD parameters, to evaluate and manage the patients with an LVAD in the perioperative settings, and to identify and treat common left ventricular assist device complications in the perioperative period. There are 5 million Americans living with heart failure, and the number is predicted to become 8 million by 2030. Unfortunately, 50% of these patients will die within 5 years of diagnosis. And despite heart transplant availability, we don't do more than 2,000 cases a year. However, more than 100,000 of these patients could benefit from a left VAD implant. There are 3 big indications for LVAD. One is a bridge to transplant, one is the bridge to recovery, and more lately becomes a destination therapy. And the bottom line is that 84% of the patients who receive a heart transplant do survive to 2 years. However, this is not, like I said, this is not readily available, and the medical management patients do have a mortality higher than 90%. When they looked at 20,000 LVAD placed between 2003 and 2014, actually it was they had extremely good results. So 60% of these patients survive a 2 year after the LVAD was officially approved, and 58% was during the HeartMate 2 trial. In 2017, the Roadmap trial results were published. This was a prospective non-randomized observational trial. They looked at 200 patients, 97% of them had an LVAD, and 100 of them had medical management. And when they looked at event-free survival, and they defined event-free, not just the survival, but improved functional status, decreased key events like acute heart failure and hospital admission, the LVAD arm was actually free from death and urgent transplantation, compared with the medical treatment that actually had just 40%. And this is probably secondary to hemodynamic effects of the LVAD that increases the blood pressure, the cardiac output, increases the organ perfusion and organ function. Also, it seems to have an effect on contraction and relaxation, in improved mitochondrial function, and apparently does reverse some of the remodeling and increases the left ventricular compliance. Interestingly enough, they also find that has neurohumoral effects, probably secondary to increased organ function and perfusion, with decreased vasopressin catecholamines and cytokines. Like everything in life, it's a balance. It's a balance between the cost of device, of initial admission and rehospitalization, and seems to be more than $200,000 spent with the initial admission and VAD implantation, with the quality of life, functionality of this patient, longevity, and independence. The next few slides are a little bit dry. It's pure physics, but please bear with me because it's important to understand the 2 types of pumps that are used for LVADs. First is the axial pump, and this is used in HeartMate 2. It's a flow-dependent pump, and also it depends of the delta pressure, which means it pushes the hardest at low flow rate, and it's a pusher. It's a steep and inverse linear relationship between the flow and the head pressure. And just a very low increase in pressure, like you see here, in between 40 and 80, will have a very linear increase in the flow between 3 and 7. These pumps are afterload sensitive, which means increased SVR will decrease the delta pressure, and they have a high risk of suction events. They also have a high risk hemolysis, and these are the, unfortunately, risk of thrombosis and increased risk of strokes. The next generation of pump are the centrifugal pumps, and these are blind to the absolute value of power, which means very low volume state will result in less significant suction event and less thrombosis. They are throwers, which means they're just going to throw the blood from the inflow to the outflow, and they are extremely sensitive to afterload. And this is, you're going to see how very, the same increase in pressure from 40 to 80 millimeters mercury increases the flow from 0 to 10. It's a very linear increase in pressure. The higher the RPMs in the HeartMate 3, because these are the centrifugal pumps that we use nowadays, will increase the flow very little. They are actually at large flow swings. They behave like pulsatile pumps. And like I said, the HeartMate 3 are the valves that we place mostly in the last few years. And this came after 2017 when the Momentum 3 trial was published that showed the survival at 2 years compared with the axial flow pump, which worked to HeartMate 2, is actually higher. And also they have less replacement and reintervention in 2 years. Regardless the type of pump, there are 6 VAD components. One is the inflow cannula, that is the cannula going to the left ventricle. One is the pump itself, the outflow cannula that comes from the pump to the ascending aorta, the drive line from the pump to the controller. The controller is going to be the monitor where you're going to see all the parameters. There is a drive line and batteries. The VAD parameters that we follow are the speed, which is the RPM, the pulsatility index, the flow, and the power. The optimal VAD speed is echo-guided and needs some parameters in order to be tailored to that patient needs. The left ventricular size needs to be within normal range, and the Sugar cardiac index higher than 2.2. Should be no right or leftward shift on the septum. It should be some degree of pulsatility, and the aortic valve should open. And this is an image of a good RPM and good VAD speed, where the left ventricle is a normal size. You can appreciate the inflow cannula. As you see, the septum is midline with an opening of the aortic valve, and the right ventricle seems to be dilated, but kind of the normal, normal size probably for that patient. As we increase the RPM to 11,000, as you see, the left ventricle is completely decompressed, and actually this is the equivalent of a suction event. The aortic valve is closed. The cannula is completely towards the septum, that it's bouncing towards the right ventricle. Also, when we do a echo, we should look for aortic insufficiency and if there is any evidence of thrombus. The VAD power measures the current and voltage applied to the motor and varies directly with the pump speed and flow. The higher the pump speed, the higher the VAD power. The pulsatility index is the third VAD parameter that we look for, and it's a pulsatility seen by the pump over a 15-second interval. It's a calculated number for a formula, and it's dependent of the RPMs, but also dependent of native heart function. The PI varies according to the intrinsic contractility, intravascular volume, and the right ventricular function. The power and pulsatility are actually in a direct relationship, and it can be a quick decision what it's not going right with the patient. If the power is high and pulsatility is high, usually it's a sign of fluid overload. If the power is high and the pulsatility is low, you have to look for hypotension and pump thrombosis. If both of them are low, these are the signs of obstruction in the inflow or outflow cannula or hypertension. And if the power is high and pulsatility, if the power is low and the pulsatility is high, it's the equivalent of a suction event secondary to hypovolemia tamponade or the right ventricular failure. The VAD flow, it's a calculated number. There is no flow detector. And this is important because, as we're going to talk at the end of the lecture, when the patient is not responsive, even if you see a valve flow of 3 or 4, that doesn't mean that's not equivalent with the cardiac output. So there are a few factors who affect the valve flow, and this is the preload, the right ventricular function, and the afterload. The normal parameters are set for each type of pump. So it's important to know at what degree is a deviation from the parameters that are set by the company. So usually the hardware, you'll see low RPMs with high powers. HeartMate 2 have a little bit higher RPMs because it's an axial pump flow. And HeartMate 3 has RPMs between 5,000 and 6,000 with flows between 3 and 6. So I'm just going to go to a quick recap, such way to be easy for you to assess it's not going well when the patient is hypertensive or non-responsive. The pump speed is a direct measurement to the motor. Usually it's established by the physician. So when you're going to see that the pump speed is going down, expect a suction event. At the end of the suction event, the pump will increase back to the fixed speed setting. The power is a measure of current and voltage, increases as RPM increases. However, if it's not related with the RPM, so the RPM was not adjusted by the physician, the gradual power increase may indicate pump thrombosis. The pulsatility index is calculated from pump power and increases with left ventricular preload or contractility, but decreases with the outflow or inflow obstruction and volume status. The flow, it's a completely estimated number based on power and RPMs. It's pretty imprecise. It flows less than 3 liters and can be actually overestimated if power, if the pulsatility index is high. The VAD comes with some complications. Most common complications are cardiovascular and hematological, but also infection, thrombosis, and renal insufficiency. Most common complication is dysrhythmia. It's typically due to a suction event when the inflow cannula goes in contact with the ventricular septum, but also can be atrial fibrillation, ventricular tachycardia that are related with the remodulation of the heart. The right heart dysfunction actually complicates 20% of the left ventricular assist devices, most of the time in the acute period immediately after implantation. The aortic regurgitation is induced by LVAD itself and can be severe and actually can induce recirculation of the blood. And stroke can be prevented by aggressive management of hypertension and aggressive management of thrombosis. Bleeding is one of the most common complications in patients with LVAD and has multiple etiology. Most common is a post-surgical bleeding immediately after implantation. But with time, this patient acquires von Willebrand deficiency and angiodysplasia and AV malformation. That actually reflects in the reason why this patient comes for frequent upper endoscopy and colonoscopies, because they do have frequent GI bleeding. On top of that, these patients are on anticoagulation. The goal INR depends on each patient. Usually it's in between 2 and 3, but can increase to 3.5 to 4 when the patient has thrombosis. So this patient can be a little bit overcoagulated with high risk of bleeding. Hemolysis is another hematological complication that it's manifested by stroke, increased haptoglobin, hemoglobin, and LDH. Also, it's very important in considering inflow or outflow obstruction and pump dysfunction. The infection can be VAD-specific infection, and these are cannula-related pocket infection and driveline, but also can be non-VAD-related infection like pneumonia and UTI. These patients do have multiple hospitalizations, so unfortunately, the majority of the infections are multidrug-resistant bugs. The thrombosis carries a very high mortality, up to 50%, and may present as hypotension, heart failure, power spikes with low pump flow, signs of stroke, or evidence of hemolysis. Well, what should you do? Like we discussed, that patient needs to come to the operating room as soon as possible. Most important is to call the VAD coordinator or the cardiologist. These patients have assigned a VAD coordinator. They have their phone number on speed dial, so they know exactly how to contact them. And also the VAD coordinator and the patient cardiologist has a lot of insight about that patient device and also the complications that the patient developed during the VAD placement and after the VAD placement. Physical examination is as important as any other patient. If you have time and it's an elective case, preoperative medical optimization when possible in coordination with the cardiologist is ideal. You should obtain a baseline EKG, echo, and lab test if you have time. The majority of these patients have AICDs, so this AICD should be managed the same way they would manage any AICD in that particular type of procedure. And all of these patients are anticoagulated. So the anticoagulation needs to be held, bridged, or reversed, depends how emergent the case is. The type of anesthesia depends on the type of procedure. These patients do tolerate very well regional and max sedation for minor cases. There are a few cases of neuroaxial anesthesia for cysto, but that involves normal INR and reversal of the anticoagulation. General anesthesia, it's pretty well tolerated in major cases. The intraoperative care needs standard ASA monitors. Arterial line needs to be ultrasound guided because unfortunately these patients are non-pulsatile. If the procedure is minor, you can actually measure Doppler blood pressure. There is no need for invasive monitor. Cerebral tissue oxygenation monitor is actually a good substitute for pulse oximeter because the pulse oximeter is extremely unreliable given the lack of pulsatility. And if you expect a large fluid shift, central line is indicated. P line has very little indication in these patients if you don't expect right ventricular failure because of the pump change or a patient is not known to have severe pulmonary hypertension. The external defibrillator should be in place if you deactivated the AICD. Have any sort of inotrope support available, depends how the blood pressure is, if it's dobutamine, epinephrine, or milrinone. Try to optimize the preload and decrease afterload. If the patient goes under some laparoscopy or thoracoscopy, gradual insufflation and position changes is indicated, given the fact these patients are preload dependent. Like I said, these patients are pulseless. Sometimes you can get an automatic blood pressure measurement, but in studies actually showed that number, it doesn't correlate with the arterial line reading. Ideal, it's arterial line placement, but manual Doppler correlates very well with the arterial line. So if it's a minor procedure or the patient is awake and you do just regional Doppler measurements should be enough. Ideal map is between 70 and 90. Most common intraoperative complications are the ones who are common to all patients, like hypotension, hypertension, arrhythmia, and bleeding. But some of the patients can develop right ventricular failure intra-op or immediately post-op, and they can develop suction events. The causes of hypotension can be VAD-related, and these are pump failure, pump cannula obstruction, and high RPM. Especially in case of trauma like the one that I presented, you have to be very careful because it can be fracture of the cannulas and drive lines and can be patient-related. Secondary to hypovolemia, arrhythmia, right ventricular failure, aortic insufficiency, and cardiac tamponade. And this is why the bedside TT, if possible, even during the case, it's ideal. So you can quickly assess the ventricle. If it's a small right ventricle, can be hypovolemia. If it's a large ventricle, pulmonary hypertension and right ventricular failure can be one of the etiologies. So be careful to correct the hypoxia, acidosis, and hypercapnia. If both of them are large, consider VAD thrombosis. You can also assess the IVC diameter and collapsibility and assess for any effusion or tamponade. Compared with a regular regular shock, we do have few extra numbers that can tell you what kind of shock the patient is. So in hypovolemic shock, the flows are low and the PIs are also low. Patients can have suction events. The echo shows a non-dilated right ventricle. The patient has low urine output, low SVO2, and elevated lactate. Of course, the first things to do is to give fluids or blood, depends what is indicated, but also in the patient with LVAD, you can decrease temporarily the RPM such a way to decrease the risk of suction events. If the patient is in cardiogenic obstructive shock, the flows are low and there are multiple suction events. The right ventricle looks dilated and the CVP is high. The patient has cold extremities and low urine output. And the causes are multiple, and these need to be discussed with the cardiologist. The distributive shock shows us high VAD flow rates with hyperdynamic heart, with normal or high SVO2 and elevated lactate. And this needs to be something else to be considered, special than usual sepsis and anaphylaxis, is the liver dysfunction secondary to acute right ventricular failure. Hypertension, it's one of the possible complications and increases the risk of suction events and stroke. So as much as possible, we should avoid increasing SVR like direct laryngoscopy and pain. The treatment is treat the etiology, but also vasodilator like short-acting nicardipine, nitroglycerin, or the longer-acting hydralazine. The suction events occur when the preload is decreased, which increases the negative pressure within the left ventricle, so the cannula moves towards the septum. Most common cause is hypovolemia. Very rare can be tamponade right ventricular failure, but it gets complicated by arrhythmia and hypotension. The management is intravascular volume, such way the left ventricular size increases rapidly and decrease RPM. The arrhythmia is a pretty frequent complication of left ventricular assist devices, especially intra-op. The most common is atrial fibrillation, but ventricular fibrillation and ventricular tachycardia can also happen up to 60% of the cases. Luckily, these patients do have the AICD, and if they don't, they should have the Zoll pads on. The treatment, it's usual arrhythmia treatment. Check the electrolytes. Potassium should be kept above 4.5 and magnesium above 2.2. We should be careful and manage hemodynamics and suction events. If it's a new onset and it's hemodynamically unstable, the patient should be cardioverted. The usual medication used is amiodarone for supraventricular and ventricular tachycardia, or lidocaine for ventricular tachycardia. In general, we try to avoid sotalol beta blocker because of the negative inotropic effect. Intra-op, the most common cause of bleeding is the typical cause of bleeding, surgical bleeding, secondary to lack of suture. But these patients are anticoagulated and they do have angiodysplasia. Also, the platelet activation during the blood going through the pump induces dysfunction. And also they have von Willebrand disease, which is acquired secondary to high shear stress. So any type of coagulopathy needs to be treated right away. All these patients should be reversed before the surgery. Extremely rare, we use vitamin K for reversal, even for elective cases. FFP is one of the quick reversal. However, it comes with a high volume. So usually we try to avoid FFP. And most of the time we use prothrombin complex concentrate for quick reversal, especially in emergency cases. The right ventricular failure is a pretty common complication. Most common cause is fluid overload and manifests with increased CVP if you have invasive monitor or hypotension. And like we discussed, the TTE reveals dilated non-contractile right ventricle and shift of the septum. The treatment is inotropes, and the choice of inotrope depends on the blood pressure. Dobutamine or milrinone if the patient is hypertensive, epinephrine if the patient is hypotensive. Temporarily, you can also increase the RPMs. The postoperative care, It's standard PACU care if it's a small case and not complicated, or ICU if it has complicated hemodynamics. Extubation criteria are the same like for any other patient. Pain control needs to be very aggressive in order to decrease the SVR and the risk of stroke. And the heparin infusion or the anticoagulation needs to be resumed on a conversation between the cardiologist and surgeon. I apologize for this busy slide, but this is the guidelines that were published in 2017 from the International Society of Heart and Lung Transplant. And like I said, the first thing to do when you know that you're going to have a left ventricular assist device patient is to collaborate with the cardiology team, specifically with the heart failure team that has that patient under care. For non-emergent procedure, you have time to reverse the warfarin. Sometimes if it's a low-risk procedure, actually the patients go under procedure without any reversal with an INR higher than 2. And I talk especially about upper endoscopy and colonoscopy. And the bridging therapy should be considered if the patient is off warfarin for a long time. If the procedure is emergent, the warfarin needs to be reversed with FFP or PCC. During the procedure, it's ideal to have a cardiovascular surgeon in the operating room or immediately available. The monitor can be an arterial line, but Doppler is appropriate if the procedure is minor. And post-procedure, the anticoagulation needs to be restarted after conversation with the surgical team and the cardiology team. One of the most common question is if we should do CPR. And the question comes because during the CPR, there is a high risk of actually dislodging the cannulas. However, in 2017, the American Heart Association published the guidelines for ACLS in patients with mechanical circulatory support. And they are, if the patient has altered mental status and it's no responsiveness, and the clinical findings are reasonable in terms of there is some urine output, if you can monitor that, or it's a capillary blood flow seems to be okay, then monitor for other causes. However, if these are not present and you cannot assess for blood flow in an unresponsive patient, you should start CPR. If the patient is intubated, end-tidal CO2 value less than 20 millimeter, an unresponsive patient is a sign of cardiac arrest, and it's reasonable to start chest compressions. And I'm going to present a quick protocol how to assess. What's different about this compared with regular ACLS is like after you assess for breathing and ventilation, you have to assess for a VAD-HUM because the VAD-HUM is not present. That means the pump is not function and the CPR needs to be started. If there is a VAD-HUM and the MAP is lower than 50, then you should start CPR. If the MAP is not lower than 50, so there is VAD-HUM and unresponsive patient with a MAP higher than 50, then you recheck your monitors and assess for other causes of altered mental status. In conclusion, the number of patients with left ventricular assist devices coming to the OR for elective procedure is increasing. Always involve the mechanical circulatory support team. TTE and TE is a key study to assess the most common complications and to assess the etiology of those complications. Many times getting IV access or invasive monitoring can be very challenging. All the VAD patients are preload driven and afterload sensitive. The patients with HeartMate 2 are more preload sensitive than afterload sensitive. The patients with HeartMate 3 are more afterload sensitive. If hypotensive, you should consider volume first.